Today we will be discussing about the angle and foot complex and its kinesiology. Angle and foot is a complex of joints and bones. It contains around 28 bones and which makes 25 joints. The major joints in the angle and foot complex include the tibiofibular joint, talocrural joint or angle joint, exact angle joint. The talocalcaneal joint is also called subtalar joint. Talonavicular and talocalcaneo-cuboid joint. It's also called transverse tarsal joint, tarsometatarsal joints, metatarsophalangeal joints, and interphalangeal joints, and a total number of 25 joints include containing 28 bones. Now, like any other joints, this angle joint is also having stability function and mobility function. So, first of all, we will discuss about what are the stability functions of the angle joint. The first stability function is, it is a stable base of support for at different postures without excessive muscular activity. So, a person can stand long hours without much muscular activity with the help of this angle and foot complex. And the second thing is that it is a rigid lever for the push-off phase or end phase of gait cycle. So, these are the two stability functions. The first one is it's a stable base of support for the different postures without disturbing, without excessive muscular activity. And the second one is it is a rigid lever for the push-off phase of the gait cycle. Now, we will discuss about the mobility function. The first mobility function is it contains lots of joints. So, it is flexible enough for shock absorption. And the second function is it can change, depends upon different terrains, so that a person can walk through different terrains. So, an angle joint is a foot and angle complex is having two types of function. The first one is stability function and the second one is mobility function. So, because of these functions, the angle and foot complex is the one of the important joint complex in the body. Now, we will go through the different movements available in the angle and foot complex. The one of the two important movements are plantar flexion and dorsiflexion. Plantar flexion means it is the movement of the foot away from the tibial bone. That is, this movement is assisted by the flexor muscles of the foot. Now, the second motion, it is the opposite motion of the plantar flexion, that is called dorsiflexion. That is, here the movement is towards the anterior side of the tibia, and this movement is assisted by the extensor muscles of the foot. Second type of movement is eversion and inversion. Eversion means it is the turning of the angle and the foot outward away from the midline. So, that is, all the weight will be on the medial edge of the foot. That is eversion. And inversion means turning of the angle inward. That is, weight will be on the lateral side of the foot. So, second type of motion available in the angle and foot complex is eversion and inversion. Another type of motion is abduction and adduction. It is abduction and adduction means again almost similar like eversion and inversion, but here abduction means it is away from the midline and adduction means towards the midline motion. Now, there are some complex of motion in some of the joint like subtalar joint and transverse tarsal joint. We cannot differentiate between the abduction, adduction or eversion, inversion and plantar flexion, because these joints are designed in such a way that there won't be separate movements and we will get a combination of movements. So, this combination of movement is called pronation and supination. Pronation can be defined as it's a combination of eversion, abduction and dorsiflexion. And supination can be defined as it is a combination of inversion, adduction and plantar flexion. Another movement which is seen in the toe is toe flexion, toe extension. Toe extension means movement of the toes towards the plantar surface or plantar surface of the foot, and toe extension means movement of the toes away from the plantar surface of the foot. So these are the some important movements seen in the ankle and foot complex. Now we will go through some important bones in the ankle and foot complex. One of the most important bone is tibia itself, and it is also called shin bone. And it is a medial bone, and it is the largest bone of the lower leg. The proximal end of the tibia, as already discussed in the knee joint, it forms the part of the knee joint, and the lower side or distal end of the tibia forms the ankle joint along with the fibula. Now the distal end of the tibia stick out under the skin on the medial side, and this area is known as medial malleolus. Now the second bone, it is a lateral bone, and it is fibula. Fibula is located on the outside of the lower leg, and tibia is a weight bearing bone. At the same time, the fibula is a non weight bearing bone, and again it articulates with the tibia, and it forms three joints with the tibia, and the distal end of the fibula is visible under the skin on the lateral side, and this area is called lateral malleolus. So you can see on your leg itself there is medial malleolus and lateral malleolus superficially. Now the next bone is the calcaneus or calcaneum. The common man use this as heel. It is a heel bone. Layman can use it as heel bone. It's also so. Calcaneum is another important thing of calcaneum is that it is the attachment of the most of the important muscles of the lower leg, and once all the body weight will be transferred through the knee, through the ankle, and that weight is passed through the talus bone, and after the talus bone there are half of the weight will be transferred to the calcaneum bone. So while running, walking, about half of the total body weight is supported by the calcaneum bone or calcaneus bone. Second, another important bone in the ankle and foot complex is the talus bone. It is a wedge-shaped bone located between tibia, fibula and calcaneum. It is one of the key bone, and all the body weight will be transferred through the talus to the calcaneum and anterior side of the foot, and it is the fulcrum point from which ankle joint is able to move. Now the foot complex can be divided into three parts. The first one is a rear foot, second is mid foot, and the third one is forefoot. Rear foot consists of the bones talus and calcaneum, that is the posterior side of the foot, and the mid foot is the middle side. It contains the tarsal bones, and the forefoot contains metatarsals and phalanx. So the foot can be divided into rear foot or hind foot, mid foot and forefoot. This is the classification of the foot according to the positions of the bone. Now we will go through some important joints in the foot. The first is the tibiofibular joints. These are the joints formed between the medial tibial bone and the lateral fibular bone. So between tibia and fibula, there are three joints can be seen. The first one is a superficial or a superior or proximal tibiofibular joint. Second one, an inferior or distal tibiofibular joint. It is also called tibiofibular syndesmosis. And there is a middle tibiofibular joint. It's also called interosseous joint or interosseous membrane. So, between tibia and fibula, there are three articulations, a superior, a middle, and an inferior articulations. Now, we will go through the proximal tibiofibular joint. Again, it's a plain synovial joint between tibia and two flat facets of the fibular head and posterolateral tibial condyle. So, this joint does not have much movement. There is a slight gliding action is available in the proximal tibiofibular joint. Now, the distal tibiofibular joint, again it's a compound fibrous joint, and this joint is strengthened by certain ligaments. The ligaments are anterior tibiofibular ligament, posterior tibiofibular ligament, and interosseous ligaments. These are the three ligaments which supports or which strengthen this joint. Now, the movements of this joint. Movement of the distal tibiofibular joint is also very less, that is only to accommodate the wedging of the wide portion of the talar trochlea between malleoli during dorsiflexion. So, this is the only movement, a very small amount of movement will be available in the distal tibiofibular joint. Now, we will go through the actual angle joint. It is also called talocrural joint. It is formed between, it is a hinge type of variety of joint formed between the articulation between the distal tibia and fibula proximally and talus distally. That is, a proximal articulation is formed by the distal part of the tibia and distal part of the fibula, and this part makes a mortise, and the part of the talus, the part of the talus makes the distal articular surface. Again, it's having only 1 degree of freedom. That is, it can be moved only in only one plane, and one type of movement will be available. The motion available is plantar flexion and dorsiflexion. So, we already discussed what it is, what is plantar flexion and dorsiflexion. Now, we will go through what are the proximal articular, how the proximal articular surface is formed. A proximal articular surface is the mortise formed by the distal end of the tibia and fibula. It forms a mortise, and that is the proximal articular surface of this talocrural joint. And the distal articular surface is formed by the talus bone itself. The talus bone is having corresponding 3 articular surfaces. A lateral articular facet or lateral articular surface for the fibula, a medial facet for tibia, and a trochlear or a superior facet for the mortise. So, it's having this, like any other joint, talocrural joint is also having 2 articular, the proximal articular surface and distal articular surface. Proximal articular surface is formed by the mortise, formed by the tibia and the fibula, and the distal articular surface is formed by the talus. Talus makes 3 corresponding articular facets, which is for fibula, one is for fibula, one is for tibia, and one is at the superior facet or trochlear facet. Now, joint capsule of the talocrural joint. So, the main function of the joint capsule is the protection of the joint or stability of the joint. So, the main structures which give the stability of a joint are the capsule, the ligaments, and the muscles. Here, the joint capsule is thin anteriorly and posteriorly. So, as it is thin anteriorly and posteriorly, the stability of the joint has to be taken by, or it is reinforced by, laterally and medially by some strong ligaments. These ligaments are called collateral ligaments of the angle joint. So, we will be discussing regarding the collateral ligament of the angle joint later. Then, regarding the capsule is attached superiorly to the borders of the articular surface of the tibia and fibula, and it comes inferiorly and attached on the talus bone. Now, we will be discussing, we already discussed that there are some ligaments which give strength to this joint, talocrural joint or angle joint. So, we can see there are medial ligaments and the lateral ligaments. We will be discussing about the lateral ligament right now. The lateral ligament it contains 3 ligaments, or we can say it's having 3 parts. The names of the ligament, this is also called lateral collateral ligament of the angle, and the names are anterior talofibular ligament, posterior talofibular ligament, and calcaneofibular ligament. And the medial ligament is called deltoid ligament. The name deltoid, why the name deltoid is that the shape of the ligament is fan shaped. So that's why it is called deltoid ligament. It is also called medial ligament of the angle or medial collateral ligament of the angle. Now, this ligament, medial collateral ligament, is attached proximally to the medial malleolus, then it fans out and it goes to the talus, calcaneum, and the navicular bone. So that's the medial collateral ligament. Now, once we discuss about the ligaments, one thing we should not forget is that regarding angle sprain. It's one of the common injuries seen among the players, that is especially those who are playing on court, so among the football players and tennis players also, because there are lots of lateral movements will be there in these sports. So angle sprain is a common type of injury seen among the players and athletes. And among this angle sprain, lateral angle sprain is the most common, that is 95% of the angle sprain is the lateral angle sprain. The mechanism of injury is a forced inversion and plantar flexion movement. In this movement, in force, the lateral ligaments get stretched and it may get torn if it is that much forceful. And once it is injured, there are chances of, if the proper treatment and proper rehabilitation is not done, there are chances of re-injury. A lot of time, there are lots of cases where the person, after a lateral ligament injury or an angle injury, the person does not have taken the proper rehabilitation protocols and proper training, then he gets re-injured and angle become totally, it keeps on injuring a lot of time. Then mechanism of injury, we already discussed, it is inversion and plantar flexion motion. A forceful inversion and a plantar flexion causes these lateral ligaments stretched and it gets injured. And sometimes there will be tearing of the lateral ligaments. Usually among these 3 ligaments, we can say ATFL, anterior talofibular ligament, ATFL, is the most commonly injured. 75% of the angle sprain is the ATFL injury, and ATFL and CFL around 25%, and all the 3 ligaments together it is very less. Occasionally there may be chance of injury. Sometimes even the medial ligament may get injured. An opposite movement, an eversion sprain causes an injury to the medial ligament, and the medial ligament, it is a fan-shaped ligament, it is also called a deltoid ligament, and it is one of the strongest ligament in the angle, but still it may get injured. So medial ligament, an eversion sprain or eversion type of injury can cause an injury to the medial ligament. Now there is another type of angle sprain, it is called high angle sprain. High angle sprain means sometimes along with this ATFL and lateral ligaments, there may be chance of injury of the ligaments between tibia and fibula. So this type of injury is called, sometimes it may be along with this lateral ligament injury, otherwise sometimes it may be separate high angle sprain. Now what are the treatments? So we will usually people used to ask, what are the treatment for, what is the immediate treatment for this, and what are the treatment, how we can treat this angle sprain. The most common is the rice method. That is, first of all, the rest is the most important thing. It should not be re-injured without proper rehabilitation. And another important thing is that ice. And next is compression and elevation. The rice methodology has to be done as to the treatment as treatment protocol. Then if the angle got injured, there may be lots of chances of re-injury again. If it is not properly rehabilitated, it may get re-injured. It may be either a functional or mechanical. So this condition is called chronic angle instability. Now, there may be chance of other injuries also. So it should be differentially diagnosed whether it is an angle sprain or any other injury of that angle joint. It may be an anterior process fracture of the calcaneus, it may be a lateral process talar fracture, or a osteochondral fracture of the talar dome, or a fracture of the fifth metatarsal. Otherwise, a syndesmotic injury can also see, there will be similar type of finding may be seen. Now, which are the motions available in the angle joint? The motions are, we already discussed, it is plantar flexion and dorsiflexion. Dorsiflexion is produced by the anterior compartment muscles of the leg. The movement is limited by passive resistance of the triceps surae and tension of the medial and lateral ligaments. So that is dorsiflexion, and the muscles which causes dorsiflexion, that is dorsiflexors, are tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. These are the anterior muscles, and which causes the contraction of this muscle causes dorsiflexion of the angle joint or a talocrural joint. We'll just go through one important muscle, that is tibialis anterior muscle. The muscle starts from the top of the tibia, and then tendon crosses the angle joint, and it attacks the base of the first foot bone, and it crosses at the joint, allows for multiple motion. And major motion available, or major motion by the contraction of these muscles, are dorsiflexion at the angle joint, we already discussed, and inversion of the foot is the other motion by the contraction of the tibialis anterior muscle. And there are lots of methods to strengthen the anterior muscles or dorsiflexors. So usually the used methods are TheraBand method, or you can use the weight by using TheraBand. The strengthening of the dorsiflexors can be done. Now, next type of motion available in the angle joint is the plantar flexion. So the plantar flexion is produced by the muscles of the posterior compartment of the joint. The plantar flexors include gastrocnemius, soleus, plantaris, tibialis posterior, flexor hallucis posterior, and flexor digitorum longus are the main plantar flexors. Among these, gastrocnemius and soleus is considered as primary plantar flexors of the angle joint, and these two bones, the two muscles, the gastrocnemius and soleus, make a common tendon, and the name of the tendon is called Achilles tendon. Again, the plantar flexors can be strengthened by using different exercises like this, and TheraBand also exercise can also improve the strength of the plantar flexor group. Now, one other important point to be noted is that during dorsiflexion, what is happening is that the angle motis is in contact with the talus. So what is happening is that the anterior part of the talus is during dorsiflexion, the wider anterior part of the trochlear surface of the talus is in contact with the motis during plantar flexion. That is, first of all, what is happening is that during the anterior part of the subtalar joint. Now we will be discussing about the subtalar joint. Subtalar joint is formed between the talus and calcaneum. It's having three articular surface between thallus and calcaneum. And that is, the articular surface are anterior articular surface, posterior articular surface, and a medial articular surface. Between these articular surface, there is sinus tarsi is there. Then ligaments. Ligaments are the major supports of the joint. And the ligaments, there are two types of ligaments work on this subtalar joint. The ligaments are the ligaments which support the angle joint and the ligaments which is only for the subtalar joint. These are the two types of ligaments. We already discussed the ligaments which support the angle joint also. So these are the two types of ligaments which support the subtalar joint. Now, we already discussed is that it's having three articular facets or three articular surfaces. So its motion is also a triplanar motion. The triplanar motion in a single axis. So the name of the motion is called supination and pronation. So the supination means, we already discussed what is supination. Supination is calcaneal inversion, calcaneal adduction, and calcaneal plantar flexion is called supination. But it is in the non-weight bearing position. But in the weight bearing position, the calcaneal inversion, the calcaneum can move, go for inversion. But in the case of calcaneal adduction, here in talar abduction will be there. In case of calcaneal plantar flexion, talar dorsiflexion will be there in the weight bearing position. Along with that, there is a tibiofibular lateral rotation also will be there in the weight bearing position. Now in case of pronation, there will be calcaneal eversion, calcaneal abduction, and calcaneal dorsiflexion in the non-weight bearing position. At the same time, in the weight bearing position, there will be calcaneal eversion. It is same as that of the weight bearing position, but at the same time, calcaneum cannot abduct and dorsiflex in the weight bearing position. So instead of that, talus will move opposite. So we will get the same movement, that is talar adduction in case of calcaneal abduction, talar plantar flexion in case of calcaneal dorsiflexion, and associated movement is tibiofibular medial rotation also will be available in the weight bearing pronation. So once the foot is in supinated position, that type of foot is also called high arch foot or pes cavus. And if the foot is in pronated position, the arches become down, and this type of foot is called pronated foot or low arch foot or pes planus. Now we will go through the next joint. It is transverse tarsal joint or mid tarsal joint. It's a combination of two joints. It is formed by the articulation of the calcaneum with the cuboid and the articulation of the talus with navicular bone. So here joint line, there is a S-shaped joint line can be seen between these bones. So S-shaped joint line, and this is the point where the foot is divided into hind foot and mid foot. So S-shaped joint line dividing the hind foot from mid foot and forefoot. So it contains two types of transverse tarsal joint, contain two joints. The first one is between talus and navicular bone, that is also called talo-navicular joint, and proximal part of the joint is the anterior portion of the head of the talus, and the distal part is the concave posterior aspect of the navicular bone, and it is supported by three ligaments. Inferior aspect, there is a ligament called spring ligament, and the medial aspect, the same deltoid ligament, and the lateral aspect, it is the bifurcate ligament. So these are the ligaments which support the talo-navicular joint. Now the second joint in the transverse tarsal joint is the calcaneocuboid joint. Again, this is supported laterally by lateral band of the bifurcate ligament, dorsally by dorsal calcaneocuboid, and inferiorly there are two ligaments, that is a short plantar ligament and the long plantar ligament. These are the structures which provide stability to the calcaneocuboid joint. Now again its movements. This also having, it is having two types of axis, a longitudinal axis and a transverse axis or oblique axis. The longitudinal axis, it is almost like an anteroposterior axis from anterior to posterior, but not exactly anteroposterior axis. It is a 15-degree inclined from the transverse plane, that is 15-degree up from the transverse plane, and a 9-degree inclined medially. So it is the first axis, it is the longitudinal axis. Now the second axis is the transverse axis. It is almost like this, that is a 57-degree medial to the sagittal plane and a 52-degree superior to the sagittal plane. Now in the first axis, longitudinal axis, the motion available is, all the motions are available like dorsiflexion, plantar flexion, eversion, inversion, and abduction, adduction. But the inversion and eversion motion predominates, or 90% of the motion is eversion and inversion, and associated dorsiflexion and plantar flexion will be there in the longitudinal axis. But in the transverse axis, just opposite of this, that is plantar flexion and dorsiflexion and adduction, abduction predominates. So once we conjoin these two, we will get again a pronation and supination of the joint. Okay. Now this joint function, transverse tarsal joint function or movements. Any movements in the subtalar joint or subtalar region causes motion on the transverse tarsal joint. Now we studied the movement of the subtalar joint. It can undergo, it can go for supination, it can go for pronation. Subtalar joint supination is the locking of the joint, that is locked or close packed position of the subtalar joint. So once this joint is locked, the transverse tarsal joint also goes into a supination motion. Once it is locked, the transverse tarsal joint also goes into a supination motion. But at the same time, if the subtalar joint goes into a pronation movement, the joint, it goes into a pronation movement, the subtalar joint become loose packed. That is, loose packed means the movement can be done in any direction. That is, the joint is lax and the ligaments are lax and the movement can be done in any direction. That is, the transverse tarsal joint is mobile. Again, this also become mobile and become loose packed. So transverse tarsal joint function, any movement in the subtalar region causes motion in the transverse tarsal joint also. So subtalar joint we already discussed, it can go for either supination or either pronation also. In case of subtalar supination, it means that the joint become locked. That is, it's a close packed position of the joint. So in this close packed position, the transverse tarsal joint also goes into supination. But in case of subtalar joint, in case of subtalar pronation, the joint become loosely packed. That is, the ligaments are lax and joint is free to move anywhere. So the movement will be depend upon the terrain. So it is loose packed. So transverse tarsal joint is mobile and it is also become loosely packed and it can move depends upon the terrain. Now from this picture you can understand very easily, that is here in this case, first of all the first joint is the subtalar joint, it goes into pronation. Along once the subtalar joint goes into pronation, the transverse tarsal joint also goes into pronation. So what will happen is that the lateral side of the joint become lifted, that lateral side of the foot become lifted. So the base of support decreases. So body will be having a compensatory mechanism to improve the base of support. So it is done by the opposite motion, that is supination of the transverse tarsal joint, and body gets the proper base of support again. Next joint is the metatarsophalangeal joint. As the name implies, it's the joint between, it is formed between metatarsal and phalangeal bone. And it is a condyloid joint with 2 degrees of freedom. That is, it can be moved in 2 directions, in 2 planes. The movements available here are flexion and extension, and abduction and adduction. Flexion and extension we already discussed. Adduction and abduction. Abduction means away from the midline, and adduction means towards the midline. The movement away from the midline is called abduction, and towards the midline is called adduction. So these are the movements available in the metatarsophalangeal joint: flexion and extension, abduction and adduction. Now, next type of joint is the interphalangeal joint. Interphalangeal joint is the joint between phalanx. That is, it is a synovial hinge type of joint. A hinge type of joint is the joint which is having only 1 degree of freedom. That is, the motion available is flexion and extension type of motion. The variation in this interphalangeal joint is that the great toe is having only 1 interphalangeal joint. At the same time, the other toes, that is the second to fifth toe, is having 2 interphalangeal joint or IP joint, and these are the proximal interphalangeal joint and distal interphalangeal joint. So that's about the different joints. It's a brief discussion regarding the joints, and now we'll go through the arches of foot. So everybody will be knowing what is the importance of arches in a building. Like that, here arches is one of the important structure in the foot. It is a weight bearing mechanism of the foot, and it is the load bearing and shock absorbing mechanism of the foot. So all the weight of the body is transferred through these arches. So a proper arch will give the proper biomechanical movement of the body. So the foot is having a total of 3 arches. 2 longitudinal arches, that is medial and lateral longitudinal arch, and 1 transverse arches. And among this, the medial longitudinal arch is the largest arch. But all the arches are formed by different structures of the body. The arches is formed by the bones, the ligaments, and the muscles. So even once the muscular tone is not sufficient, the arches won't be there. Once the ligament is lax, arches won't be there. Some biomechanical abnormality in the bone, arches, there won't be proper arches. So that's why the arches won't be present at the birth, because there won't be any muscular tone of the lower limb, the foot muscles, once the child is at the childbirth, and once he start walking, the muscles get toned and the arches develop. And the proper arch, the researchers are saying the proper arches develop properly at the 13th age of life. Now, the height of the arch is maintained by different structures. The first and the foremost is the plantar fascia. Second one is the intrinsic foot muscles. And the third one is the ligaments, especially the most important ligament is the spring ligament, and other joints, especially the stability of the bones and joints. These are the structures which maintain the arches of the foot. Now, longitudinal arches. Longitudinal arches, it's an arch where posterior side is with calcaneum formed, posterior side formed by the calcaneum bone and anteriorly to the metatarsal head. And the lateral arch is lower than the medial arch, and the talus bone is considered to be the keystone or key bone of the longitudinal arches, because all the body weight will be transferred through the talus, and it is divided into 2, one to the calcaneum, one to the anterior side of the arch, one to the posterior side, one to the anterior side of the arch. So the keystone of the longitudinal arch is the talus bone itself. Now there are two conditions. Once we discuss about the arches, there are two different conditions we have to discuss. The first one is pes planus and second one is pes cavus. Commonly it is known as flat. Pes planus is commonly known as flat foot. That is, it is actually a dropped arch. A dropped especially medial longitudinal arch is called pes planus or flat foot. So either it may be a flexible, it may be rigid flat foot. So pes planus means it is a dropped arches. That is, the foot will be completely on the ground and there won't be any arches of the foot. And the second type is the pes cavus. Pes cavus means it is a raised arch. Arch will be more and it is less common. And main negative thing in this pes planus is that the pes cavus is that there will be poor shock absorption and there is more chance of stress fractures because all the weight will be transferred through these arches. Now the transverse arch. Transverse arch is easy to visualize at the metatarsophalangeal junction, and once it comes anteriorly, the arch becomes completely reduced. The transverse arch is completely reduced at the level of the metatarsal heads, with all the metatarsal heads parallel to the weight bearing surface. So at the level of the tarso-metatarsal joint, arches are easy to visualize, but at the head of the metatarsals, the arch is completely reduced. Now another important structure in the foot is one of the most important, we can say, one of the most important structure is the plantar fascia. Plantar fascia is an important important part of the arch of the foot, and it is a dense fascia covers the entire length of the foot. So it's originating from the medial tubercle of the calcaneum. Start from the medial tubercle of the calcaneum, divided into three bands: a medial band, a lateral band, and a central band. And the central band is one of the strongest band, and it passes anteriorly and attached to the proximal phalanx. And usually players comes to you saying that I have severe heel pain, and the heel pain is more in the first 2 steps in the early morning once we get up from the bed. So without any checking, even we can say it is the cause is a plantar fasciitis, because the most peculiar feature of the plantar fasciitis is the morning pain in the first 2 steps, because in the night, or once the plantar fascia, once the joint is relaxed, usually while sleeping, the foot goes into plantar flexion and the complete plantar fascia will be relaxed and it become contracted. So first 2 steps, the plantar fascia becomes stretched and there will be severe pain. So it is because of the inflammation of the plantar fascia, and the condition is called plantar fasciitis, and it is commonly seen in long distance runners and especially those who are not changing the shoes after 3,000 or 4,000 kilometers. Now we will go through the foot muscles. These are some intrinsic muscles of the foot. So intrinsic muscles of the foot, that is the muscles seen on the plantar surface of the foot, can be divided into different layers. The superficial, we will just go through the names of the muscles. The superficial layer contains abductor hallucis longus, abductor digiti minimi, and flexor digitorum brevis. Middle layer contains quadratus plantae and lumbricals. The deep layer consists of flexor hallucis brevis, abductor hallucis, and flexor digiti minimi. Then the interosseous layer comes. It is especially plantar interosseae and dorsal interosseae. So these are the intrinsic muscles of the foot, and once this muscle become weak or paralyzed, again the arches of the foot is also lost and different movements of the foot also will get lost. Now, before we concluding, we'll go through the different muscles again, which causes the important movements of the ankle and foot complex. The first one is the plantar flexors, which causes the plantar flexion motion. The plantar flexors include gastrocnemius, soleus, plantaris, tibialis posterior, flexor hallucis posterior, and flexor digitorum longus. And dorsiflexors are tibialis anterior, extensor hallucis longus or EHL, extensor digitorum longus or EDL, and peroneus tertius. These are the plantar flexors and dorsiflexors. And another important muscle groups are everters and inverters. Everters include peroneus longus, peroneus brevis, peroneus tertius, and extensor digitorum longus. Inverters are tibialis anterior, tibialis posterior, flexor digitorum longus, flexor hallucis longus. In the ankle joint, during dorsiflex, once the ankle joint goes into dorsiflexion, the trochlear part or the superior surface of the talus is having an anterior side of this trochlear surface is wider. At the same time, the posterior side is narrow. So once there is dorsiflexion and plantar flexion, once the dorsiflexion occurs, the mortise is in contact with the wider anterior part. So the stability, as the surface area increases, stability increases. So it can withstand around 450% of the body weight in dorsiflexed position. It is one of the stable position of the ankle joint. At the same time, once the ankle goes into plantar flexion, the narrow posterior part of the talus is in contact with the mortise. So what will happen is that there is the surface area or contact area is very less. The stability of the ankle joint is compromised at the level of at this level. That's why there is more injuries, more ligament injuries, or more injuries seen in the plantar flexed position. Second type of training errors commonly seen is the ignoring the sports. That is, for example, a person, a runner, he is doing a swimming event or a swimming training for a running event. That is ignoring the sport, and he is not doing the running training, he is doing a swimming training only, and this may cause another type of training error commonly seen in the runners. And another type of training error is due to it, and if there is no cross training, that is, if he is trained for one muscle or a single type of training he is doing, and he is not doing the training for the opposite muscle, this causes a muscular imbalance. So this some muscle will be strong, the other muscle will be weak, and this causes some muscular imbalance. For example, hamstring may be weak and quadriceps may be strong. This type of imbalance causes injuries again. This is another cause of injury. Next error commonly seen, the training error, is the person undergoes a persistent high intensity training. A persistent high intensity training without lowering the intensity. So there won't be any easy days. According to the training principle or conditioning principle, once there is a high intensity training, there should be some easy days, that is with low intensity training. So once there is no easy days, the person gets fatigued up, and this causes injury again. Another common training injury commonly seen is sudden increase in mileage or increase in intensity with and not giving an adequate rest. So there is a sudden increase in mileage or sudden increase in intensity, and again this causes again injuries. Now a single time once if the person starts his training and is do a very severe training, this is another cause of injury commonly seen. Or a competitive session, a severe training, this according it is similar to a severe training, this also causes this another cause of injury. Now a repetitive uphill running or a downhill running or uphill training or a downhill training, again this also causes injuries. Now another extrinsic factor is the surface. If the person is doing his training or competition on an uneven surface, it causes that it's a chance of injury, it predisposes to injury. Now he is doing his training on slanted surface, slanted roads. It causes more pronation and supination of the foot and causes injury. Or otherwise he is training on hard surfaces. Either his training is on a concrete surface or an asphalt. These type of surfaces, there will be again more chance of injuries. There is more chance of shin splint and other injuries. And another is a curved surface. A curved surface is doing this training or competition on a curved surface. This also causes injuries. Another extrinsic factor which causes injury is the running shoe or shoe. If he is not using a proper shoe, an improper shoe, that is, once you need cushioning, you are using another motion controlled shoe. So once if you are using an improper type of shoe, it causes injuries. It predisposes injuries. And if you are not using, once you need an orthotics along with the shoe, or an orthotics is needed, and if you are not using the orthotics, this also predisposes to injuries. Now there are lots of different types of shoes are available in the market. A running shoe will be available, a court shoe will be available, or a football shoe will be available, or a cricket shoe will be available. There are some variations in all shoes there are some variations in these shoes. And you are using a court shoe or a football shoe for running. So running shoe made for different sports. If you are using running in a shoe made up for different shoes, made up of different sports, this causes injuries. Now once you start using shoes, and you can use this shoe up to 400 to 600 kilometers maximum. After that, you have to change your shoe. So if excessive mileage is there, if you are using for excessive mileage, if you are using the shoe for about more than 2000 or 4000 kilometers, if you are using, so the shoes will get damaged. Again, this predisposes to injuries. Now the most important thing in the shoe is get the proper right prescription. Right prescription, the proper shoes for running should be shoes. And if sometimes the people do the training by using street shoes. So again these shoes causes bunions, corns and ingrown toenails, etc. This causes again chance of more injuries. Another factor commonly seen which predisposes injury is the improper nutrition. It may be due to a poor food choice. There should be proper carbohydrate, protein and fat ratio should be seen. It should be there in the food. So an improper food choice again causes an improper nutrition, and again it predisposes to different injuries. Then some people go for dieting, or if you are taking low calorie intake, if you are taking low calorie intake, and if you are not taking the proper calcium and iron, so it also causes injuries later. Injuries means it causes different, there is chance of fatigue and later leads to injuries. Now how we can prevent these injuries? Once you are doing the training, the progression of and speed should be gradually. Increase of the speed and mileage should be gradually. That is, you can go for 10% of increase in mileage per week. And usually interpose the hard days with easy days, hard weeks with easy weeks. So it's another principle in training. is that you should intersperse hard weeks and hard days with easy days or easy weeks. Now, drop back a small amount in every third week, that is for rest, and rest 1 or 2 days per week. A small rest is necessary, otherwise there may be chance of fatigue. Better to use all the runners should use, better to use, keep a training diary or a running diary. So that this running diary, according to that you can modify or you can improve or progression can be done accordingly, so that there won't be any overtraining. So in order to avoid overtraining, better to use a training diary or a running diary. Then proper hydration has to be, proper water has to be taken. Proper hydration should be there. And replace the shoes in every 400 to 600 miles. And choose the proper fitted shoes. Proper fit shoes for your foot. And always you should have an alternative shoe. And never go for a competition with a new shoe. And always there should be a proper training schedule. And don't deviate from that schedule. Don't overdo it. And if you miss out any schedule or if you miss, ease back into your program. And you should not think that once you miss out, you have to take it back fast. So be patient and do the work properly. And regarding the running surfaces, try to use soft surfaces always. And avoid tight turns. Tight turns again cause injuries. And always pay attention to warning signs. That is a pain or any other color change, any other changes are there, or this type of warning signs. Once pain is there, or once muscles you feel that muscle tightness or spasm is there, these warning signs can be pay attention and meet a doctor or a physio as early as possible. And if you feel like there is a change in the natural running style, or there is a favoring of the injured area, this you have to go your doctor or a physio as early as possible. And start your treatment as at the first sign itself. Go for proper rest, go for proper stretching, go for icing, go for strengthening exercises and anti-inflammatory. And always don't forget for cross train, because otherwise there is chance of muscular imbalance. So always once this muscular imbalance, this is always predisposed to injuries. So develop part of the body develop the parts of the body running neglects. For example, usually the people goes for training with running. A runner used to go for training only in the muscles which is required for running. So what will happen here is that the other muscles get neglected, and this neglected muscle become weak and later leads to a muscular imbalance, and it predisposed to injuries. And with this, the other part of the body, other body parts also has to be trained. It burns the additional calories also. Now the proper nutrition has to be taken, and females at least 2000 calories per day, males up to 3000 calories per day. Proper carbohydrate, protein, fats and everything has to be taken, and food variation should be done, and proper multiple vitamin supplements should be given. Iron, vitamin C. Vitamin C improves the immune support and soft tissue support, and calcium is proper supplementation of calcium for strong bones, and magnesium for the proper muscle relax. It will help as muscle relaxant, and other antioxidant, proper antioxidant has to be taken. So that's all about the training. In this session we discussed about the different running cycles and common injuries in running, and how to improve your running skill, and how we can prevent the injuries of running. Thank you.